We had the revision in the morning, then we had the masters giving us the technical tips and the pearls, and now we have the legends giving us the expert opinion. I would now like to welcome Dr. Ken Lowy, a GI and bariatric surgeon from Kogarah, Australia, and Dr. Meenakshi Sharma, the Chief of Hernia and Minimal Access Surgery from Paras Hospitals, Gurgaon, India, to go ahead with the next session.
Welcome, everyone. I think we're going to have fun in the next sessions, I think, because the session actually involved a few of our experts, and then we had a panel, and then we're going to discuss a few interesting cases to stimulate what we learned just so far. So I think without any delay, I will introduce our panel later, but I think we introduce our two speakers first. The first one is Ramesh Punjani, who works in Fortis Hospital in Mumbai, and he's going to tell us about the tagging and things, and I'll give the floor with him for the next 10 minutes.
This session has been sponsored by GOR. We can go ahead with the presentations now. Dr. Meenakshi, will you please introduce Dr. Punjani?
Good afternoon, everyone. So it's a pleasure introducing Dr. Ramesh Punjani. He is the president of AWR Surgeons Community. He is a well-known teacher with a great deal of passion, and we all know him as the great hernia expert and a great teacher. Over to you, Dr. Punjani.
Australia, New Zealand, and India are the three countries who have organized this conference, and we are pretty excited to have this discussion on inguinal spaces. Now, this is a diagram which any endosurgeon would like to see while doing a laparoscopic inguinal hernia, whether TAP, TEP, or ETAP. And what he's seeing is actually a critically of myopectoral orifice, which is so well described by Edward Felix and Horedas. And once this display of myopectoral orifice is done, then a mesh has to be put, which will be at least 15 by 12 centimeter, and it will be deployed in such a manner that it will have 4 centimeter coverage on each of these potential orifices where the hernia can happen. Now, whether you need to fix this mesh, that's the question, that's the topic which is given to me. Mesh fixation, how, when, and why not? I am Dr. Ramesh Punjani from Mumbai, India, respected chairpersons and fellow delegates. So we'll have a discussion on this mesh fixation technique. I have no conflicts of interest. Fixation versus non-fixation, if you see, the people who believe in fixation of the mesh, we say that it stabilizes the mesh while deploying. Like in the case of TP, when you're taking all 3 midline ports, you want to deploy the mesh on the floor, and you need a stability while deploying, and that's where you probably need to be fixed at least 2 spots. There is no ballooning in M3 hernia. By EHS classification, a large direct hernia would probably need a fixation because you don't want ballooning of the mesh in the direct space. A better incorporation, it will happen. That's what a lot of people believe. It will lead to a less recurrences, a less mesh shrinkage, and it will not migrate. So these are some of the objectives that the people have in fixing the mesh. While people who do not believe in non-fixation, they say that there is a less post-op pain immediately after surgery or a few days after surgery, and again a less chronic pain because of no nerve injury. So this is the debate that has been going on. Now, if you are fixating the mesh, what are the options available? The one is you can put a tax, which could be non-absorbable or an absorbable tax. You can suture it. You can put a glue, which will be fibrin or cyanoacrylate. A vacuum suction fixation is one more method which has been described. A self-fixating meshes or anatomical meshes is still another way to go. There are a lot of studies done in this fixation and non-fixation and for a positive time, I actually tabulated them into this headings of author, journal, year, study type, subject, the subject population, and the conclusions made. And there are a lot of studies, some of them are meta-analyses and even RCTs, and there is a mixed conclusion. All of them are very sure that the recurrences do not increase if you do not fix it, but the pain is, some say it is same or some say pain is more in fixating. Similarly, this is another group of papers where again, there are a lot of RCTs in this. And they have again said that the acute pain, some say it is same, some say more. But again, the recurrences do not increase with non-fixation of the mesh. This is one very interesting paper by Craig Taylor. And what they did is, this is a randomized control trial again, wherein they have done a fixation and non-fixation, and they found that the pain score and the quantum of pain as well as the people with the pain were higher in a fixation group than in a non-fixation group. One very interesting thing that they did is, in a bilateral hernia, they fixated on one side and they did not fix on the other side. And this was blinded, which was not known to a person who was investigating. And when they asked the patient on a site where they were more comfortable than the other side, the people of almost 9% of them, they only were comfortable on the tech side, and 47% were comfortable on the non-tech side. So this goes to say that definitely the tech leads to a little uncomfortable time in a post-operative period. The predictive factors of post-operative pain are the patient who had a history of pain before surgery. So all these studies have concluded that patients who had a history of pain before surgery are the people who will have a pain after surgery. And a female patient, some of population, had a more predilection for a pain than the male population. Now, mesh migration is another concern. Is it an issue? So there have been a report, in fact, since 1991, since the hernia started, and people have seen the mesh migrating into the bladder, small bowel, colon, vagina, and scrotum. And year by year, there are reports. There are a lot of case reports in Urology Journal and other journals. But the mesh migration, what is the definition? It is defined as a mesh that resulted in invasion of any anatomical region other than the area intended for repair. A mesh erosion, on the other side, is the term where there is an invasion into an organ by an entire or partial piece of mesh gradually. However, these two terminologies have been mixed up in literature. There are plenty of reports of mesh migration from 1991 to 2002. Almost every year there are few papers, and people have seen it migrating into bladder, causing colovesical fistula, going into the scrotum, small bowel, and requiring sometimes a major complex repair and even removal of the bladder. Similarly, this is another group of paper from 2000 till as late as 2020, and people have seen that the mesh migrating into, again causing colovesical fistula, intestinal perforations, migrating into the stomach from diaphragmatic hernia mesh and into the rectum, and sometimes leading a major surgery like low anterior resection. Why do these meshes migrate? There is a very interesting paper by Agrawal et al. Where they have found that there are two types of migration, primary and secondary. A primary mesh migration occurs when a mesh moves along the anatomic places, which provide very little resistance. Now here they have attributed inadequate fixation is very important cause. And secondary migration is characterized by a gradual trans-anatomic movement, foreign body reaction that lead to erosion through the tissues, and then the meshes migrate. Do the meshes shrink with fixation? So this is one study is done by the Demire, and where they have done two groups. The one group where the mesh was fixed and sutured, the another one the mesh was not fixed, and they found that the mesh shrinkage was more when the suturing was not done. So they are again of the proponents that the suturing will reduce the mesh shrinkage. This is another study done by CMP Claus, and what they did is they have had 60 patients. 10 the TP is done with mesh fixation, in 50 the TP without mesh fixation, and they actually applied a 3 mm surgical clip at the medial inferior, medial superior, and lateral inferior corner of the mesh, and these patients were then x-rayed immediately post-op and 30 days after post-op, and they saw the movement of these clips, and they concluded that fixation of the mesh for TP repair is unnecessary. TP repair with no mesh fixation is safe and not associated with increased risk of mesh displacement. We didn't see any significant mesh displacement even though the meshes were not fixed. So there is a mixed report whether fixation of the mesh would prevent the migration of the mesh. Now let's see the world guidelines, world hernia guidelines by the Hernia Search Group. And they have made the statement, in almost all cases, any type of mesh fixation in TP repair is unnecessary. The another statement they made is atraumatic mesh fixation techniques are favored to reduce early postoperative pain. And they have a strong recommendation, and which has been upgraded, saying that traumatic mesh fixation is recommended in a patient with a large direct hernia, that is M3 in EHS classification, undergoing TABP or TP to reduce the recurrence risk. Now so therefore the tax will be required. So where will you not tax? So this is one area which is a triangle of pain, where there will be all the three nerves which can be injured in laparoscopic surgery are there, and therefore no tax will happen below the iliopubic tract. And similarly now near the ASIS, If you see here, there is aloingual and aloepigastric. Now, even though they don't appear into the endo hernia space, but they are there in the intramuscular plane just deeper. And therefore, if you tack it or near the ASIS, they are likely to go and hit the nerve. And therefore, near the ASIS is another area where the tacks are not recommended. So therefore, the tacks in TAPP, this is the display of myopathy orifice. And we are putting a mesh, which is 15 by 12, which is crossing the midline. The tacks will be on the Cooper's ligament on the superior medial part over the rectus and one on either side of the inferior epigastric, but certainly not near the anterior superior leg spine or into the triangle of pain. So this is how the tacks are done in TAPP, and this is in actual position where these tacks are put. The tacks in a totally extraperitoneal repair, this is a small video, where the TAP is done through 3 midline ports. And here you will have to fix the mesh before you deploy, otherwise you will not be able to lay it on the floor. So this is how it is done. Again, the lateral port is above the iliopubic tract, and the end of the gun is felt by the outside hand to see that it is on the anterior abdominal wall. This is tacks again in ETAP. When they are to be put, they can be put again in the similar manner by palpating, putting on Coopers and palpating that they are above the iliopubic tract, and then the mesh can be deployed. This is the fixation with the suture. Now, when you are doing the suturing for fixation, you can actually judge the bite that you are taking, and you can be just going through the peritoneum and little pre-peritoneal tissue and not go through the muscle. And that's why probably the sutures have a little more security, and you can again fix it in the similar manner. A fixation in the glue is a great idea, where after the mesh is deployed, you can actually glue it up with any of these glues. Only thing is that the availability and affordability of the glue is a question in our country, and therefore many of us cannot use this glue. The vacuum suction fixation has also been described, where this gentleman has actually designed one 3 mm instrument like a Varis needle, and after suturing the peritoneal flap, he inserts that into the next to the mesh, and he sucks out the carbon dioxide, and he deflates the entire abdomen, and then he pulls out this, and he says that this peritoneal flap themselves would put the mesh in position, and there is no need of fixation. A self-gripping mesh is another idea which came forward, and where people say that the meshes with tentacles can be put, and they can actually remain there for some time till the mesh is incorporated, and that will not require a fixation. However, there are studies done, and this is by Amar Ismail, where he found it did not favor. There was no difference in the self-gripping and the rest of the meshes as long as post-operative, which were fixed where the post-operative chronic pain was concerned. And similarly, this is one meta-analysis which has showed that there are similar outcomes whether you put a self-gripping mesh or a normal mesh with the fixating devices. Therefore, the best thing probably would be a no fixation. This is an ETAP procedure where an anatomical mesh is put, and it has been deployed properly, and now the abdomen is desufflated without fixation. In conclusion, avoid fixation in female patients, in patients who had a pain before surgery, in lateral hernias, in indirect hernias, and females anyway have inguinal hernias, so there is no need to fix these meshes. In a medial hernia except M3, so where there is a large direct hernia, more than 2 centimeter, that is where probably you will have to put a mesh, tacks, or you will have to fix the mesh. Use glue if available and affordable in all cases. Sutures are probably better than tacks because you can judge the bites that you are taking. The ETAP is probably better. You have a wider vision and you may not fix the mesh. TP also, if you take a lateral ports, probably you will not be using the fixation devices. But in TAPP, most of the time, you will have to use some sort of fixation. The anatomical meshes are somewhat better. That is a questionable, and so also self-gripping meshes. Thank you so much. Respected chairperson, it was a lovely time to be with the ANZAWR.
Thank you.